Okay, so let me welcome everyone. I'm Brian Golden. I am the Sandra Rotman Chair in Health Sector Strategy at the Rotman School of Management, Professor of Strategic Management, and the Academic Director for the Center for Health Sector Strategy. So it's so nice to see so many people joining us today, and the numbers on the counter keep going up. Before we begin, I'd like to make an acknowledgement. Although this event is taking place virtually, we always wish to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, while we're meeting virtually, Toronto is still the home to many Indigenous people from across Turtle Island, and we're grateful for the opportunity to work on this land. Our center is pleased to be hosting today's panel event, the final in our Health IT series, the Economics of Primary Care Post-COVID. So for those who are still joining, we have a terrific lineup of panelists, and I'm going to pass it over to our host for the evening in a moment. But four experts on primary care who will talk to us about what has been happening from a business and economics perspective in sector in Canada over the last 2 years. And then we'll take a look at the ahead to the future and talk about what might that future look like. How can we ensure that we have a high-performing primary health sector going forward? And that is a topic and an issue dear to the hearts of those of us at the Rotman School. Our host and moderator tonight is Will Falk. Will is a senior fellow at the C.D. Howe Institute and has an appointment with us here at the Rotman School as an executive in residence. He currently serves as on the board of director at Verdo Health and First HX. He is an innovation fellow at Women's College Hospital and a senior advisor with Satov Consultants. Will is going to take it forward in a moment, but I'm here not only to introduce Will, but I'd like to periodically share with you some of the very cool activities that are happening at the center, and I will be quick. I'll just focus on one activity, having just returned from London, UK, where we had a learning module for our Global Executive MBA in Healthcare and Life Sciences. And for those who are well familiar with our programs at Rotman, I believe you'll be well familiar with this program as well. This is our 18-month program for mid-career professionals in healthcare and life sciences, public sector and private sector, where we're asking the question, what's the best way of organizing, funding, delivering care, innovating, commercializing across the globe? So not a Canadian program, though partially based in Toronto, but also based in Singapore, London, UK, and the San Francisco Bay Area. So modules in each of those locations over 18 months. We are nearing the end of our recruiting cycle for the next year, but of course, we will be launching a new cohort every fall. And so for anyone who has any interest in this in this program, please don't hesitate to reach out to us. It is just about the most exciting thing we do at the Rotman School in our executive program, certainly for me. I will stop sharing at this point and turn it over to Will, who will take it from here. And thank you, Will, for joining us and for supporting all of the work we do at the Rotman Center for Health Sector Strategy, whether it's our research, policy advising, or, as I've just described, our programs for MBA students in healthcare and life sciences. Will, over to you.
Thanks, Brian. I really appreciate it and appreciate the introduction and the opportunity to be here today. I'm just going to add a plug. I've had a chance over the course of the last year to interact with a bunch of the students in the global program. It is just a tremendous cohort and a lot of learning amongst those folks. I've actually had occasion to now work with a couple of folks in some of the startups I'm involved in, and it's great to see and a great program. We have a fun panel tonight at an interesting time in our history. We're going to hear from Darren Larsen, Erik, Sande, Wayne Samuels and Zayna Khayat over the course of today. I didn't say that in the right order, so that's going to confuse the heck out of everyone, and I'm sorry. It's actually going to be Darren, Erik, Zayna, and Wayne. I'll let them tell you a little bit about what they do in their jobs. Each of them has a slightly different point of view on primary care. Darren's now over at Telus. Erik is running a big part of the Medavie Health Services. He's one of the two CEOs. Zayna is at Teladoc after years over at St. Liz. And Wayne has moved to Medicentres Canada, where he's running a big practice in multiple provinces. I say it's an interesting time in primary care because COVID really kicked the crap out of a lot of primary care revenue models and opened up some new ones. It was a very tough time for a lot of fee-for-service docs to make a living. I think we've all lived portions of that, but primary care had pretty unique challenges and some pretty unique stressors as well that we've dealt with through each of the first 5 waves, and I'm sure we'll continue to deal with for some time to come. As a result, there's been tremendous business model innovation. And while each of our 4 speakers today is intimately involved in making sure that care is of high quality and great access and continuous, we are today going to focus a little bit on the economic models. We get to do that because we're a business school, so we get to talk about economic models sometimes, and we are going to do that. I'm hoping that people will give us permission to do that and not find that off-putting. I will say that each of the 5 of us and everyone at Rotman cares deeply about the quality and access parts of primary care as well. And I think that's really all I wanted to say by way of introduction. And I'm going to turn the floor over to Darren. So Darren, you're up first.
Yeah, thanks a lot, Will. One of the advantages of, I guess, being the family doctor in the crowd is you get to go first. So that means, I guess, I get to be a little provocative and get to kind of stir the pot up a little bit for everybody else. So once again, thanks a lot for having me. I am Darren Larsen. I am a family physician at Women's College Hospital. Also right now serve as the Senior Medical Advisor for Accenture Canada and the Canadian Healthcare Practice. And as Will said, as of Monday, actually, I'm starting a new position with TELUS Healthcare Centers as the Chief Medical Director of that clinic entity. So have had a really long experience looking at primary care. I started way back in 2001 at the Ministry of Health, building the primary care models for Ontario. These are what we know now as family health teams, organizations, and groups. And then from there, so a lot of time with the OMA and Ontario MD with the electronic digitization of the work that we do in primary care. So when I think about the economics of primary care, this is a hard one to tackle because really economics are different depending on what level you're looking. So me as a physician, my individual view of the economics of running a practice, myself or a nurse practitioner or someone running a small business, will be very different than it would be when I go one level up to, say, an organized primary care model grouping like a family health team or a family health organization. The economics of that kind of organization are very different than the small business that I run as an individual physician. And then even above that clinic kind of level, we're looking at the economics of a health system, whether it's an integrated care system like an Ontario Health Team in a relatively local environment, or moving up the ladder to what would be regions, or in fact, the Ministry of Health or government. So each of those lenses is really different when you look at economics. And many of us, when we're in practice, we're focusing on the patient, obviously, first. We're looking at this small business, trying to make it viable, trying to keep it a going concern, and trying to make sure that we're offering the best care we possibly can with the most efficiency and effectiveness that we can, which means that, a single payer model where I'm paid by the Government of Ontario for the work that I do, obviously, if I reduce my overhead or reduce my costs, there's more money that comes back to me personally in my income. If I hire more people or create a better longitudinal experience, in some cases, a more robust or large clinic, that affects my bottom line. personally. So the economics are really very interesting for those of us working in primary care. And it's super important to know that primary care too is a catch-all for all the changes that happen higher up in the healthcare system. So every time there's an economic decision being made, let's say to reduce a service in a hospital or cut a fund for a specialist intervention, that filters back down to primary care, because we are left actually bundling together and cleaning up or pulling together the pieces for the care that may have been discounted or not happening at another level. So it's a very important thing to know. It's not a system where each of us is individually working really hard to make sure that our patients are given the best care they possibly can, with this burden of tons and tons of paperwork, new guidelines, new recommendations coming down the path for quality, new ways of measuring, data being given to us, accountability agreements, etc. It's a difficult. And our negotiation, having been the physician ratified, %. Although that contracting and offers for primary care just over a 1% raise per year for the next 4 years. When you look at the cost of inflation and you look at the prices of doing business now, with medical inflation being somewhere around 7 or 8% per year, we are seeing overall potentially a reduction in our incomes with this new agreement, which means we're going to have to think really creatively about how to reduce costs in order to maintain a bottom line for our own individual incomes. So sometimes even things that look like a good thing in terms of a new agreement may have ripple effects we don't necessarily see down the line. But the other thing to note about primary care and the economics is we don't really have a view into our cost. We don't really have a view into what we spend at the system level. We have very little in the way of accountability for that, and we're not an integrated, coordinated group. And certainly if we do something really well in terms of efficiency that drives down costs down the line, because we have no gain sharing or risk sharing, we don't actually see any of the benefit of that personally. So if I save the healthcare system money by keeping a person out of hospital, I know that's more work for me, but I don't see the benefit of that necessarily, except for perhaps maybe more beds and more ability to get a person in who truly needs it. So these lines of sight into the outcomes of our efforts are very important to realize. They're not clear for us. It's very, very murky, and we don't see much beyond the individual patient encounter. So all of that leads to a fair bit of inefficiency in terms of the integration and coordination of effort and from an economic model, and we have no really good way of reining that in. And physician services are somewhat driven by payment model, but we have to recognize too that as we've learned now during COVID, we're really driven by patient demand. So we have a lot of incentives for doing the right thing, but we don't have a lot of incentives for doing less of the wrong thing. And patients may now be favoring things like access, as they should, or immediacy, or the ability to speak to me or a physician at any time for any problem, which has been much more liberated through the virtual care world that we've been living in the last 2 years. So, interesting times in terms of the patient experience and the drivers that will move us forward. And I think the driving of patient expectations, the fact that governments are going to be nearly broke or certainly in a cash-strapped situation in COVID recovery. There's more access to better data for policy decisions, but none of it really is coming from me as a provider. Corporate Canada moving ahead with health system creation in a way that puts the customer service lens on care, which we're not really very used to. And many patients being willing and able to pay for more convenience and more access, as we've seen with the onset of virtual care. These are just some examples of how the system is going to radically change in the next 5 or so years. But what I really want to focus on is the idea that we need to be innovative, we need to be creative, and we're going to require some really important public-private partnerships to achieve success in an overarching economic model of what primary care costs, what it produces, and what its outcomes are. So primary care has to be seen as more than just a business. It is a business, but it's a business that has the potential to have multiple ripple effects on the economics of the greater healthcare system. And it's pretty clear to me that not all costs in the future will be borne by government, even in a highly funded public healthcare system. So the economics here for me are basically 3 things: driven by patient demand and expectations, driven by accountable payment structures I think we're going to be seeing in the next few years, and innovative models of system design, which will likely need to involve corporate Canada and corporations that are putting patients at the center of their customer service plan around attachment to a body of trust. In other words, pre-existing relationships, pre-existing, favor with the companies moving forward, drugstore chains, telecom companies, etc., to kind of keep patients in the loop and guide them through this circle. So this is where I'll start, and I'll stop there and leave the next to Zayna, I believe.
Yeah, no, that it's going to be Erik in a moment.
Erik,
but that's great, Darren. I really appreciate you getting us grounded there, and I look forward to seeing you at Telus next week with some of the many business models that they have there, in terms of how that all rolls out. I noticed that I didn't even have to ask people to start heckling in the chat, that people just did that. So I guess we've acculturated everyone. I forgot to mention that you are welcome to heckle the speakers in the chat and put things in. And I also will mention that if you are on Twitter, if you'd please use the hashtag RotmanHealthIT, I'd appreciate that. So thanks, Darren, and Erik, over to you.
Thanks very much, Will, and thanks, Darren. So my name is Erik Sande. I'm the president of Medavie Health, and I've been doing that for close to 10 years. And prior to that, I was with Philips Healthcare, and I ran their global home monitoring, remote patient monitoring business. And I also am the chair of the board for Healthcare Excellence Canada, one of the PCHs based out of Ottawa. So just a bit of context before I get going. I'm going to talk about community care. That's the lens that I work in healthcare delivery in the community. Unlike Darren, I won't be talking about the physician specifically, other than as a team member in primary care as we deliver it in the community. Bit of context, Medavie Health is a community care organization. We have about 5,000 clinicians, nurses, paramedics, RTs, OTs. We've got a sprinkling of pharmacists and some physicians as well. We're about 8 provinces. Most of our business is in the EMS business, ground, air, and communications around ambulance services and mobile integrated health. We have a large clinical home care team. We're also involved in medical communications. That's telehealth, remote patient monitoring, triage centers. More recently, we're into mobile mental health, and we also do some clinical training as well for a variety of people. Our clients are federal, provincial, ministries of health, health authorities, and municipalities. And what we're finding is they're increasingly asking us to offer care in the community and move that primary care, or move that care, where it's appropriate, out of acute settings into the community. And what they talk to us about are they're looking for better outcomes. They're looking for more capacity in the system, certainly. They're looking for faster care for patients and how that turns into a better patient experience. And of course, they're looking for better value for money. They understand that a lot of care that's taking place in the acute system can be done better in the community. But when they talk about value for money, they're not necessarily talking about driving down the cost of community care per se. The ones that are a little more visionary are talking about system costs. So they often understand that an investment in the community can often provide a long-term, much better return through the entire system itself. Complex discussion and one we've been having for years, but there is some light in the tunnel there. So I'm going to talk about sort of 3 different things here that we do. One is we're very good at integrating teams in the community and driving economic value out of that. Mostly that's around getting various team members to practice closer to the top of their scope of practice. And that allows us to assign the right clinician to the right patient, right time, and right cost. Technology, of course, you can't avoid that conversation, nor would you want to. So we look at technology through 2 main aspects. One is a productivity, logistics, care coordination view, and then the other is availing ourselves of new channels that are available for patients in the community. And then the business models themselves. So we have many arrangements contractually where we are paid essentially a managed service fee. So we manage an operation on behalf of a ministry or a health authority, and we receive a payment on sort of a cost plus payment on that. But increasingly, we're trying to go to at-risk models where we're actually paid for meeting and exceeding certain metrics. So in one particular contract we have, We only get paid if we reduce visits to the ED from the community, if we provide faster time to care when it's ordered, if we increase capacity in the community for more client touches, more patient touches with the same size team. We get better engagement for physicians. We measure the patient experience, and of course, cost. We manage the cost effectively as well. So I just want to talk about a few examples of those programs that we're running. In New Brunswick, we have the privilege of running not just the EMS system, but also all the clinical home care, and we work with the telehealth system there too. About a dozen different clinical professions are involved in that. We're trying to be, well, we're not trying, we are clinician agnostic as in terms of care, but we're setting up a system whereby if a 911 call comes in and it's an emergency, we'll dispatch an ambulance team. But if it's not an emergency, let's say it's a COPD issue, we'll dispatch maybe a paramedic team that evening to do an assessment to make sure that that patient has been treated and is comfortable. And if the assessment says, you know, we really should bring a nurse in or an RT, we'll be able to book an appointment for that. Get a follow-up the next day with 811, and the appointment can happen a few days later. We're going to be providing an EHR at some point to integrate with the physicians. You know, at the center of that model, of course, is the physician and the patient. We want to make sure that that loop is closed, of course. One of the programs that we are going to be launching this summer is around managing primary care for unattached patients in the province. So and this is in New Brunswick. They've got, say, 80,000 unattached patients who do not have a primary care relationship. We'll be setting up a system where they can phone a 1-800 number, for example. Their issue will be triaged by an NP. And at that point, they'll decide if it's an episodic issue that could be handled quite successfully through a virtual consult. They'll give that patient a token. They can go online, book an appointment with a physician virtually, and deal with that. But for at least half, probably more, we think, of course, face-to-face care with a physician is going to be most appropriate, and we'll be able to book appointments at a variety of clinics with a physician within a 24 to 72 hour period based on the urgency of the issue itself. That as well will have an EMP, so an EHR, so everybody is in tune with what's happening with that patient. We can track it and follow and do all the follow-ups as well. A third one that we've recently launched is around mental health. So in the province of Prince Edward Island, we're now managing community crisis mental health. So again, it's a medical triage center where calls are answered, people in distress or require some assistance with mental health with phone. A nurse practitioner trained in mental health will take that call, triage it. They'll be able to suggest self-care if appropriate, make a referral into an agency where appropriate as well. But if it is a higher acuity issue, we have a number of mobile teams that will drive to the patient. Typically, it's a nurse practitioner and an MSW, both trained in mental health. We'll be able to visit that patient wherever they happen to be and to be able to assist them with that particular crisis. We're starting to see some really interesting results out of that, which of course have economic consequences. Hospital admissions for these patients are down about 10%. The response of ambulance crews themselves is down 75%. The response of police department visits is down over 90%. And 80% of those patients are now being referred into allied agencies. So we're getting to use the capacity of those systems at a much, much higher rate than was happening later. And of course, you know, mental health is a massive exacerbator of chronic conditions that are out there. Quite often, if we're able to visit a patient in home based on their request for some assistance with a mental health issue, we find out there are a lot of other primary care issues that are either the cause of it or are being exacerbated by the mental health issue. So we might be able to assist them with a problem they have with some sort of chronic condition and to be able to be very holistic with the treatment there. One of the interesting economic questions that we're just starting to ask here is, with mental health in particular, how do you integrate that with private insurers? So we know that mental health coverage, it's not in the Canada Health Act, and that a lot of people are covered privately. Many, unfortunately, do not have that. But if you did have private insurance, wouldn't you want to know the kind of coverage that patient has and be able to integrate that into the public and the private plan so you could bridge from one to the other and back again and have a more seamless program for that individual to assist them. So, you know, that's one of the ways we're thinking about working with private insurers there. And just so people know, my organization is run by a Blue Cross affiliate. So, you know, we're not in discussion with them in particular about it, but it is an idea that is coming up. So those are 3 examples of where we are working with a variety of government stakeholders, not necessarily to drive costs down in the delivery of community care in the primary setting, but to manage costs for the entire system. Hard to measure for certain, but I think we're going down the right path where we're starting to chunk out pieces that we can control, where there is baseline data, and we can prove that we're making gains or losses as it may be against that. So with that, Will,
Erik,
yeah.
how big is your Ontario EMS footprint at this point? How many counties?
In Ontario, we run EMS systems in Southwest Ontario and Chatham-Kent, Elgin, Perth area. We're also in GTA. We run about 300 vaccination clinics this year. We're running the GoVax buses. If anybody's seen that, we're doing the last mile of vaccination, typically in communities where it's hard to get people, for equity issues, they have difficulty getting out to get their vaccinations. And so we've had I don't know how many tens of thousands at this point. And then we're looking at a variety of other programs in Ontario too.
I mean, I've been watching the way you guys have been changing the definition of primary care in Atlantic Canada for a while. It's great to see. It's driven by some environmental differences that are there that are fascinating, I think. I want to acknowledge, actually, one of the silver linings on COVID has been that we've been expanding the pool of who attends these things. And I noticed in the registration today that there's almost 70 people, probably not that many attendees, but 70 people registered from outside of Ontario. So welcome to all of you from across Canada and in fact from some other countries as well who've decided to join today. And thank you, Erik, very much for that. Zayna, you're up next, and I'll give you feedback if there's any issue on the audio quality.
Yep. So hi, everyone. So just quick background, I've been in the innovation space for a while, teaching a course with Will Falk for a while here at the business school on health innovation. And then probably, the pinnacle was 4 years of basically being the chief innovation officer in the home care space like Erik. And I chose that sector because I really know and believe, and it's true, that all of care will move to the home and only a little bit will happen in facilities. So I wanted to be part of that future. And then kind of, just joined Teladoc as, for me, really the vector to enable this future. And it's the world's largest virtual care company in medical care, so primary care, acute care, mental health, and chronic disease management. So a couple of lenses. I'm going to share a slide, Will. Is that bad?
It's okay, but no more than 2.
No, okay. Well, there's 4, but here we go.
Okay, that's right. Go.
So, I think we keep using this word, and a few of you hinted at it. I think Canada is the worst at putting their head into a box about a certain word: virtual care, primary care, remote monitoring, and then they define it by the things that's happening today versus what's the mandate of that model. And, I see it as, kind of the place that quarterbacks care, develops plans, and connects people to whatever they need to get the job done. And, I'm a vegan, but I am totally ready to make hamburger meat out of the sacred cows of, what we still obsess about and frame around who's the kind of human that's delivering that care. And we obsess that it has to be a physician, a family medicine physician, and how they're paid. And then where it's happening. And I just think that's such a 19th century thing that, we need to move on from, and, thankfully, there's starting to be a growing current that we can all agree that it needs to be relationship-based, as Darren said, that we should actually care about the results of the work, not who's doing it, where they're doing it, and how much they're getting paid for transactional events. And that we obsess about the people who is the reason we all have a job, which is patients and their families, and then, the livelihoods of these clinicians. So if that's what we define as primary care, I'm all for making it 21st century and unlocking the economics. And I just wish we can emancipate in this country from the nitty gritty of the current people doing it and where they're doing it versus what we're trying to achieve. So, at Teladoc, I think we've got, 60 million people getting care through our platforms. And for 20 years of doing that, of all levels of acuity, nobody will be surprised by our accumulated data, and we get data about the primary care experience of all of the people who get care through our services around the world. But yeah, if people have access to primary care, undisputed, this is the kind of data, their issues get addressed, they adhere to their meds, they get way faster movement through the system, all the good things we dream and love and wish we can get from primary care. But it doesn't actually deliver this the way it's done today. Either people don't have access, as we just heard, and people are putting in the chat. So when 100,000 of my fellow citizens in Southwestern Ontario don't even have access to this, well, that's a very big problem. And I would submit those who do have access, they don't get these kind of results consistently. I personally have seen physicians get their data about all the gaps in care that, are missing. And then they're like, well, I can't do anything about it. Well, I'm sorry, that's not good enough. And so, how can we address both the lack of access and, the lack of delivering on the job to be done? This is our data from the US, but I don't think that Canada is much different. If half of people, I think we're 45% in Canada, don't even have access, and the lack of that access or the lack of good access drives massive economic consequences. At Teladoc, we've now shifted to a big, hairy, audacious goal of how do we bring those benefits of good primary care to as many people as possible, to access it and get the quality. And you are not going to do that by building more medical schools, training more people, and building more clinics, and just asking for more money from taxation every single time it's time to pay for all that. We're kind of beyond that in the 21st century. And so I'll just share one example, and there's many around the world. It's just very few have gotten to Canada. So we launched in October of last year in the US, and I get to bring this model to Canada next year. A model called Primary Care 360, nothing earth-shattering. It's basically what a primary medical home is, where, it's kind of the things we all dream that primary care should be: wellness, and of course, treating and diagnosing and ordering tests, coordinating and referring in blue, and then monitoring, managing, but way better balance of those four. So then that gets you pretty much away from episodic reactive care to really balancing the person's health and helping them move through the system. And it's a digital first primary care model where you've got, a nurse or some type of allied health professional with a little mini team, and then they support pods of primary care physicians across a bunch of bricks and mortar practices. So it's deeply connected to bricks and mortar and typical practices, but it provides this layer that's extremely scalable, very, very data intensive, very proactive, and delivers amazing results. And so, this is how you can kind of scale and get the best of what we want out of primary care out. So I'll just kind of end by saying, I don't see why alternatives to the old way that, one, is not accessible and never will be at scale, and two, actually doesn't work very well for a lot of people. Why does the alternatives get held to a different standard? Can we come to a new common standard around relationships, around the results we want, and around experience? And if we do that, I actually think the floodgates will open to some models that Canadians expect and deserve, and that are already the standard of care around the world. So I'll stop there and we'll get into discussion.
Wow, Zayna, that's great. I'm really looking forward to the discussion around this question of interdisciplinary, relationship-based, clinician-agnostic piece that I think clinician-agnostic was Darren's perspective on it. But it's great to see talking about Teladoc and bringing your usual fire to the table on it. And okay, Wayne, you are up next, my friend. Go for it.
Thanks, Will. I got to say, this is a new experience for me after 15 plus years of being a consultant and trying to think about the future, I've now become an operator. And I realized that after listening to Darren and listening to Zayna, Darren's going to call me, sort of idealistic, and Zayna's going to call me a Luddite, because I'm going to talk a little bit today about what it's actually like running primary care today, and dealing with the realities where we are. So don't want to take away from the vision of the future, but for me, it's much more about where do we sit today and where do we go. Quick introduction for those of you that don't know me. As I mentioned, 15 plus years as a consultant, first with the Monitor Group, which is now part of Monitor Deloitte as a strategist, then working with Will very extensively in the health advisory side as a partner at PwC, dealing with health systems and folks all across Canada. I spent some time at Infoway, Canada Health Infoway, as the Vice President of Business Development there, driving through some of the changes there and helping with the kickoff of things like Prescribe It. And then moved over to McKesson, first in the strategy role, and then ending up where I am now as the General Manager of Medicentres Canada. Medicentres was actually sold last December, or actually December 2020 now, to the Elna Group. And that's where I'm going to base my conversation now as a member of the Elna Group and what we're actually looking to do and where we're hoping to go. So let me see if this works well here. Apologies. Okay, so let me tell you a little bit about the Elna Group itself. So first off, we are a cross-country, almost all the way across the country, right now just Alberta to Quebec, integrated health provider. The Elna Group has two main parts. The core of it is a laboratory company called CDL, which is based in Montreal. It was founded by our president and CEO, Larsen, almost 30 years ago. And is now one of the largest individual private labs in Quebec. Quebec has a different lab system. It offers about 1,500 tests to over 3,000 physicians across 450 clinics in Quebec, and is a very innovative place. We've got a partnership with Roche, and we use their latest diagnostics there, fully computerized laboratory based here in Montreal. About 6 years ago, Laurent then founded the Elna Group, starting first in Quebec, and actually looking to get into the actual provider space by acquiring clinics and looking to bring technology, much like he did to laboratories, to the clinics. As I mentioned, Medicentres, which I run, which was previously part of McKesson Rexall, was acquired by Elna in December 2020. And together now as part of Elna, we formed this network that you see here on screen. So we've got 60 plus clinics across 5 provinces. In Quebec, we do a lot of specialty work, dermatology, cardiology, urology, OBGYN, elements like that. Whereas the Medicentres network is more focused on primary care and occupational health. Medicentres, so we run primary care clinics in Alberta, Manitoba, and Ontario. And our goal is to provide all of the services that Darren was talking about in the small business so that physicians don't have to worry about that. We provide administrative services, clinical services, we staff, we do all the technology, all the operations, take care of real estate, partnerships, all of those elements so the physicians can just come and actually be physicians and focus on treating patients. In Alberta especially, all of our clinics are staffed with either nurses or clinical aides to allow physicians to really practice at the top of their license as well. So taking care of everything from forms to vitals to clinical procedures such as ear flushes, dressing changes, elements like that, which really allows physicians to maximize their time and focus on when they're treating. We've been around at Medicentres since 1979, started off as a walk-in clinic, but now do more than half of our visits as scheduled family practice pieces, and so we offer both family practice and walk-in. So when you look at this network, this looks like, to me anyways, a very typical MBA case study, right? You find a very fragmented market, you buy a bunch of assets, you roll them up, you drive scale, you save a whole bunch of money, and all of a sudden, you're becoming a big player in this space. Unfortunately, in healthcare, all those MBA case studies hit reality. What actually happens is that, as Darren was alluding to in his conversation, the economics actually change and become actually less favorable as you grow in primary care. Now, don't get me wrong, there are definitely some advantages and negotiations and purchasing, but those are a really small element of the business. And what actually happens is as you grow and actually become larger, you actually incur new costs, which aren't typically borne by small individual family practices. So for example, to run a network like this, as I'm sure you'd expect, we have to have enterprise level security. We get about 20,000 penetration attempts per day against our firewall. And so we have to make sure that we're secure and we're protected against that, which is generally not something that's dealt with by a small primary care office. We provide all kinds of finance and scheduling. Scheduling is obviously a big thing to run this across a group this large. Finance, AR, AP, billing, sort of serving our patients, those elements. We have a different standard for staff. We've offered sick pay since the start of the pandemic, so that our staff never had to worry about, do I have to come in sick or get paid? We wanted to make sure people can be healthy, but also they're not coming into a healthcare environment. We've offered PPE and sort of other COVID protections all the way across. We offer full benefits, RRSP matching, those kinds of things, which again, are things that as a medium-sized company, you're expected to offer and we want to offer, but you don't typically see. But the biggest cost and the biggest challenge here is that often these small businesses that Darren was describing, or even these small networks, 5 to 7 clinics, you often have a physician owner, an entrepreneur who's running those clinics. And they end up putting in a ton of unpaid work to do all of those things I talked about. What happens when you run a network like this is you now have to hire professional staff to do all of those things. HR, operations, finance, real estate, repairs and maintenance, all those various elements. And so what happens is you actually end up adding additional costs on, which are not borne by those small clinics, which puts you, vis-a-vis in a very unfavorable position. So given all of that, you look at this and say, well, then why would anybody do this? And the answer is because, we come here and Zayna sort of described, her big, audacious, hairy goal. We have the same one, or we have a similar one. We're looking across this and we think that primary care is still really stuck through no fault of its own, but through immense fragmentation. And you've heard some different perspectives from my fellow panelists about how they're looking to change it. We're looking to do the same thing. And our goal is no less than changing the way that care is delivered in Canada by taking advantage of some of the things that came out of COVID. A lot of bad things happened, but the one advantage we had was the normalization of virtual care. And it's going to allow us to bring a whole new model here. But, and this is the idealistic part, Darren, we're going to try to do it within the publicly paid healthcare system. So the way we're looking at this is we're creating a new system that we're actually looking to roll out later this year. The goal of this system is going to allow patients to interact with a physician in the ELNA network, provincially based to start, who has full access to their medical record. The core is always going to be a relationship with your primary care physician. But we know that the primary care physician is not available 24/7 when health impacts can show up at virtually any time. And so the question is, as opposed to asking you to wait or to go to a unconnected walk-in or the ER, how can we leverage the power of our network to provide that continuity of care? Our goal at ELNA is that patients are going to be able to interact with a physician or a member of the care team in the way that's appropriate for them and their physician. That can be over the phone. It can be a traditional in-person visit into one of our clinics. It can be through our application, which we're going to be launching later this year, a traditional video visit, sort of through the web, or it can be with a member of the care team, which is a non-physician, depending on, the specific need that you have today. The thing that's going to make this different, however, is that we're linking all of this with our EMR. And so that means patients and physicians who have signed up to this data sharing agreement, to this agreement, means that as a patient, you can interact with ELNA Medical, with your providers in person or virtually, and at any location you go to. So in Alberta, for example, any of our 27 primary care locations, or through our virtual care on the phone or virtually, both the physician and provider will have full access to that patient's medical record. While that's very helpful, of course, for this specific visit, what's most important is that visit gets logged, if it's not with the patient's primary care physician, into their record. So when their primary care physician does come back to work, they have a full record of that visit and they're not relying on a PDF or a patient's sort of memory about how that event went or some other sort of downloaded pieces that we try to patch together through our system. What this means is you're going to have a full record of the visit from your colleague. It's going to allow the colleagues to actually provide that support, which means that patients will have access when they need it, and they're going to have that continuity of care that we know is important to providing some of those outcomes. What we're looking to do is we're looking to solve that problem of access versus continuity and be able to provide that for our patients to make sure that they can reap those benefits of primary care that Zayna was talking about, but also have the access they crave that right now is driving them to some of these other non-traditional providers. And that's it. Looking forward to your questions and the discussion.
Wow. You guys are great and covered a huge amount of ground across the four of you. A fun question first that I'm sure no one will want to answer. which is that at least 3 of you have in the last few years moved from the nice public sector, not-for-profit world into the for-profit world. Do you want to discuss your motivations about going to the dark side of the force? That's not you, Erik. That's the other 3 that have gone to the dark side of the force.
Yeah, I did the reverse.
Oh, you did the reverse. So does anyone want to talk about what it's like to go to the dark side?
I mean, I can start, Will, if you want. I mean, to me, it's not, there isn't a light side and a dark side. Yeah, so I think there is really only, the best delivery of care you can possibly accomplish. And, I don't, I think it's fallacy to think that physicians paid through OHIP, through a standard kind of operating model, fee for service or otherwise, are actually fully public. 40% of my care as a patient is paid for me privately. I have my own private insurance plan for my physio, my dental, my any kind of psychology work, social work, whatever I want to do. So we do pay a lot out of pocket. Physicians and physician services are a part of that that's publicly funded. But I think when we look at what gaps are from the point of view of patients and what they need, plus what they actually are wanting and demanding, it's pretty clear to me the public system will not be able to pay for all of that. Number one, there isn't the desire to pay for necessarily all the 16 different care providers that might be part of, my potential basket of services in the family health team, but also they just can't afford to. So I think we're going to be having to look at not just bright side, dark side, or public-private, but this idea of the 2 working hand in hand. I mean, I look at how the Covaxon system was created in Ontario in a very short time with an innovative partnership between government and Salesforce and Accenture, and how fast that was out the door and how effective it was. And I just think there's no reason we can't do that kind of thing in the delivery of care in primary care. And it won't matter if you're in a big organized primary care clinic business environment or a family health team that is sort of operating in a rural area, or just a regular family doctor's office. We should still all have the ability to tap into the benefits that some of the work that comes from companies actually gives us.
Beautiful, and thank you, and touche on the COVAX thing. Zayna or Wayne, do either of you want that? No,
I'll just
okay.
say it's the light side, and I want to transform Canadian healthcare, and I need a vector to scale, and that's the private sector.
Okay, and so scalability and the ability to put the assets together. I'm going to dig in on a couple of questions. First off, for the audience, I put up a summary from Southeastern Ontario of the PSA, and page 8 has the virtual care pieces. If you haven't already seen them, you may want to open that up and have a look, because I am going to ask our panelists about the Ontario Physician Services Agreement that I believe, I don't know if we know formally yet that it's been ratified, but newsflash, it's public.
Over
Okay.
70%.
Good.
Yep.
Good. So we'll talk about that in a little while, and that's up in your chat. I want to dig in on this question of, Darren called it clinician agnostic, and I call it interdisciplinary care. Zayna, you talked about it as primary care 360. Maybe I'll go to Erik first on it, if that's okay. Erik, you employ doctors in your models. How do you think about serving doctors as one of your team members, and where do they fit?
So we're trying to build a model around the patient, and we know that the patient's relationship with their primary care physician is paramount here. Of course, not all patients have a primary care physician. So in the best case scenario, we're executing on a care plan that's been agreed to by the patient and their physician, where we're able to coordinate then a team of nurses or RTs or physiotherapists, rehab specialists, speech pathologists for strokes, etc. If we have a care plan with that patient provided by that physician who's quarterbacking it, then I think that's the optimal view for us. Then we can go out and build that team around it. Often, as we know, that situation which is does not exist, in which case we have to go out and do that on our own. Try and understand the situation with the patient, particularly those complex conditions. It becomes quite an intensive process, and build out a care plan, and then ultimately help that individual find a physician. But in the meantime, what we're hoping is that they will feel they have a team that's caring for them.
But just to dig in just a little bit, you're not starting with the doc and then handing off to others, because many of the systems that I'm more familiar with, what I think of interdisciplinary primary care teams, almost always start with the doc and then push it back out. But the doc is quarterback or something. What you're describing is a different quarterback. Is that right?
Well, we have two systems. One where there is the quarterback, the physician exists, they refer into us, and then we dispatch the team as per the care plan. But we often have patients that come in that do not have a primary care physician. So we have to deal with the episodic issue and start building from that, and build a health record and provide the team, and over time create that care plan and look for the physician to then take it on and provide more specific direction.
So often when you're thinking of continuity of care, you're thinking, how do I take this episode and build upon it to create continuity, rather than how do I assign and then continuity. Wayne, I'm going to go to you.
Sure, because I think that this is a critical question for us. And I think that coming back to the PSA, it's actually an interesting point as well, because we all talk about these interdisciplinary care teams, and we talk about sort of leveraging out. As I said, we do it in our clinics. So, we come through, and if you have certain conditions, you come to our fast track program, you get advanced access, a nurse sees you, they do probably 90% of the visit because it's well within their scope of service, but the physician still has to come in and say, yep, you did it correctly, because otherwise you can't bill under fee for service, right? So, we have to be able to change, and it's going to change through things like what Erik's doing and others. So I'm not, opposed to that, but let's be clear about how long is it going to take to change that mindset of physicians who still look at it and say, I need to be able to do this, of patients who say, I want to see a doctor, unless they don't have access to a doctor, in which case they are more open to seeing other providers, and governments who say, well, the doctor is the person here and we have to bill and this is what we negotiate. The new PSA actually requires full physicians, which are supposed to be part of these, family health organizations, these capitated models where you can bring in other providers. It's now requiring those physicians to provide a minimum number of visits themselves, right? Which takes away from this idea of, you should actually use your team to see things that are within their scope of service, and the physician should work at the top of their piece, right? So I agree that we know where we want to get to, but let's not underestimate the inertia in Canada right now from the system, physicians themselves, patients, and everybody that says the reality is what it is, and what do we do in our current system while we're testing and piloting these innovative models that we then have to scale across the country.
So I want to go to the PSA point, and I promise we'll get there, but I do just want to stick a little bit, because in either of the two cases, and Zayna, I'm coming to you on this, but in either of the two cases you guys talked about, as you switch the provider, you actually switch reimbursement systems. Well, what that means to me is that people who are architecting business models are going to run circles around this, right? Because if nurse practitioners aren't billable in province X, well, then I'll privately pay for nurse practitioners, but over here I'll do MDs, but over here I'll do mental health professionals, and here it'll be dietitians. And, sooner or later, your head just explodes trying to play whack-a-mole with all of these rules. I mean, Zayna, you're looking at bringing it into the public system. How are you thinking about it for Teladoc?
I can't say we have an answer. I've only been here 4 months as well. So I think we're starting to just scope it out and see and learn. And, we're also trying to test the model in Australia and the UK and Germany. So I'm working with my brothers and sisters in the non-US markets. But, I don't know the answer, but I think, imagine if we partnered with like someone like Wayne's org or others that have the bricks and mortar, like we would just be the layer on top. For, really a virtual primary care practice that happens to have some physical versus the other way around. So that's how we're seeing it. But, let's do this in a year and I'll give you the answer.
Fair enough. Okay, the PSA, I've sent it around. I can share my screen briefly to throw the summary up if that's helpful. I think certainly the four of you are all familiar with it. We've got Wayne, I think this is the piece you were talking about, the 20 for video and 15 for phone. Is that right? That you were
Yeah,
thinking
although
about?
I didn't find that specifically, but I know that's of great sort of interest to people who just do virtual walk-in and aren't connected to the primary care piece. I think the biggest concern on this slide is the one you highlight in your box on the right-hand side, which is the 85% for phone, which disincentivizes it. I mean, technically you say, okay, well, it's cheaper to run a phone line than a video visit, but human nature is human behavior, and this is going to disincentivize. What we saw during the pandemic was the most popular, and in many cases, especially where
I don't believe you. I don't believe you, Wayne. You're not telling me that the average phone visit takes 85% of the average effort of a physical or video visit.
I'm not going to talk about the effort. I'm going to talk about the cost to actually run that system, right? And so, to run a secure video system connected to your EMR with scheduling and online booking, all those things is actually really expensive. So it is cheaper to just pick up the phone and call somebody, but that's not how humans work, and physicians are humans, right?
Yeah, but you're now falling into the same trap that the family health team guys all fall into, describing it as if it's one system and one call. Because one of the things that I learned during the pandemic is that there are many specialty situations and many use cases where short, snappy calls are pretty good. And Erik, when you see this fee schedule, does it make you want to move into Ontario more, or to run away in horror? You're muted.
No, I mean, we'd be like, I'm with Wayne on, I'm not sure why we're looking at parsing out the calls here. We want to encourage people to use whatever, door is that they're interested in. And I'm not sure really the economics behind why they've decided to for example, care provided for certain mental health treatments at 95%. I'd have to know a little bit more behind the scenes, Will, I'm afraid.
Okay, anyone else want in on this comment?
Well, I think it's important, Will, to know that patients weren't really consulted in this. And this is what really concerns me. I mean, I'm in a clinic where I have, with a click of a button, either phone or video is an option. Patients are offered either. I do at least 90% of my virtual visits by telephone, because that's what patients want. And so this presumption that video is always better is just complete nonsense in my mind. There are many times where video is better. If you're, seeing a context and environment, etc. But, there was a study from OTN 3 years ago where patients were asked, and they said reasons: I don't want to show up on my video camera because I look like crap on a camera. I don't want the doctor to see my messy room, or, what else is going on behind. And there's lots of issues of privacy and things. So the ministry has consistently promoted this idea that video is better. And I think this comes from the old OTN days when that was considered the one and only thing. And I think this is a failing of the.
I'll pile on, Darren, and say I totally agree with you. And by the way, the recent CMA numbers on this that we posted before are absolutely crystal clear.
Exactly.
that people want video, they want the option, but it's not it's way down from phone, and it's a huge failing. And it's a really interesting example. I'm going to you, Zayna, because I know you have an alternate opinion on this, but it's actually, I think, a huge example of where within the public sector itself, you get an interest group that forms, because there were all of these people who made their living on, at one point, virtual care and video care were used as synonyms, which is insane for large parts of the country, right? Like, forcing people in rural Canada, even my part of rural Canada, which is only 100 kilometers. This is the problem with moderating a panel on a topic you care about. You talk too much. Shut up, Will. Go to Zayna. Zayna.
So just 2 points. I think, again, this Canadian thing where we just think the whole world is binary and that everything segments cleanly 100% of the time into, like, they prefer phone or they prefer video or they prefer in person, or that's not how the world works. Maybe today I don't want, Darren, you to see my house, but tomorrow I do. Or maybe this afternoon I don't mind, but I didn't like it this morning, right? Like, it's just the idea of omni-channel and choice. And then my second point, which I'm so happy there's people like, We have to stop with the visit as the unit of anything. This visit-based paradigm as the currency is ridiculous. And mammals are the same all over the world. They don't obsess with visits. It's just such a lost concept. So to me, again, we're framing everything wrong. It's not about a visit. Actually, most of the value of care is outside of the visit. It's everything that happens in between. That's the power of all the new tools, all the new expertise. And it's not going to be, a highly trained physician in a 15-minute visit is going to be how we get things to go down. So I hope we can switch to a mindset that 70% of primary care has nothing to do with visits.
But Zayna, will there be continuity?
Of course, more continuity.
That was a joke, Zayna. That was a joke, Zayna. That was a joke. I promise it was a joke.
I know.
Okay. Mental health. I was struck again today. Erik, you're going to be the second person on this, not the first. Someone else has to go first on this. I was struck again today listening to Erik that like a quarter or a third of mental health, particularly at this primary care, particularly at this point in the pandemic, has actually got a mental health component. We have screwed up mental health for my entire career in healthcare, and I don't know how we're going to fix it. There are some good employer-based models that are coming. There are some bad ones, but there are some good ones. Does anyone other than Erik, and then we'll let Erik talk, have an opinion about how we sort this out? Is it just that we're going to do a mixed public-private pay model in primary? How's this going to work in mental health?
So, I mean, Will, really the interesting thing about primary care is 40% of my day is spent in psychosocial issues, and that's really in the mental health part. Separating that out from mental illness is another issue, because we have really big problems accessing help for people with mental illness, whether it's, short-term or long-term or chronic. And I think that we have to realize that primary care deals almost consistently with every patient with a mental health issue, whether that's just the stress of having a worry of what's wrong with you or the worried well, et cetera. And we don't pay for that in any real way. We don't measure that. We don't look at it. We don't consider that kind of work valid. I don't even have a diagnosis for it in my ICD-7 billing code system that we're using still in Ontario. So it's very difficult to deal with the mental health on anything but a per visit, open box basis.
Erik?
Well, I talked about earlier, the point that Darren brings up about private coverage for this is pretty important for a lot of Canadians. So I think we do have to sort out how we manage the interface between the private and the public system. I think the recent announcement on dental and pharma means testing opens up an interesting discussion for mental health. How is that then going to start to be funded by the feds through the provinces in a more robust fashion? But what we're learning, it's really no different than primary care in this regard. The complexity of the stakeholders and the understanding of various resources at a community level, all the way up to a provincial level, is really important. And we see a lot of gaps. We also see some duplication. But we know that in all cases, we're looking at bringing together sort of a consortium or an ecosystem solution for this. So, we were tasked with looking at mental health services for Indigenous communities in Saskatchewan. It wasn't long before we realized we had to work with the government, with the Saskatchewan Tribal Council, and even with some private sponsors to bring that together so we could do it effectively. So one of the big skills here is going to be able to build those types of consortiums to tackle those solutions. And they're going to have to include private providers, I think, to be really effective.
So we start with the basic system and then off-ramp to private or off-ramp to community-based care, depending on the group that you're a part of?
Yeah, so we're either going into a crisis situation and then dealing with that particular situation, then making sure we can bridge that individual to the appropriate agency or service that exists currently. But quite often, that service may have an end date to it. And they may also have some private coverage that we want to find out about so we can bridge into that again, and then probably bring them back to the public system if they, take up their 5 visits, etc.
You made an interesting point on dental and pharma in passing, and then related it to mental health. Zayna, I'm going to say that that logic that Erik used also relates to your old world in elder care as well, that we're going to need to figure out how we go, how we make that work. Any thoughts on kind of where that takes us? And specifically, I want to get you talking just a little bit about Buurtzorg and primary care for seniors.
I mean, I think just to answer the mental health and the elder care, which was my life for 4 years, I think a lot of the answer is going to come from some new, unusual suspects that are going to be vectors to scale, that are high touch point, high visibility, and trusted either places or types of people. So like frazzled cafes at Marks and Spencer in the UK, I think Tim Hortons in all your malls that are all going to be going out of business could be a great place for elder care, libraries. I just think it's going to be really anywhere, wherever people are, versus, you know, going to a certain type of professional relegated to the formal care system. I think those models are going to explode. I think your grocery chains are going to get into it, your telcos, your retailers. Lululemon's going to have a senior line one day, all these things. So that's what I see as the path. And that's because the boomers are not going to accept waiting for a committee to have a task force, to have a committee to do a report, to do a study, to determine what we're going to do about, you know, their care gaps. So that's my sense there. And then just on home care is primary care, right? That's what I tried to, you know, bring to life in the 4 years. The model we tried in the, you know, from the Netherlands that I tried for 4 years to bring to Canada and we failed, you know, is just basically capitation and take care of a population. And mostly by nurses, right? And I think those models are highly scalable, but it takes a lot of undoing of policy here that won't really allow it at the scale it needs.
Am I safe as I go to closing and giving you guys closing comments to kind of note that each of your organizations are in the 100,000 plus, maybe million plus Canadians touched in the current year, and I guess I'm just gonna ask the question as I close. You know, what's your kind of mental model for there are a bunch of people in the chat saying that we should go into the weeds on some of the multi-modalities, but do you want to just reprise again as you close kind of where you see the action over the next year? And I'll let whoever wants to go first go first. Okay, I should.
Over the next,
Wayne, go ahead.
Yep, I'll jump in. You know, over the next year, as I said, we're looking to roll out some of these models imminently. But I'm going to be honest, we're doing it on the backs of 40 years of building, specifically over the last 10 years of building a common EMR and building what we refer to as a platform that we can roll out innovations on and improve care along, right? So we run similar processes, similar staffing models, so that any physician can operate in any one of our clinics, any of our staff can move around, and of course, patients can interact in any way. So, you know, we're going to see things in the next year that we're going to be pushing forward, but I can't say that we're just going to snap our fingers and be able to do it everywhere. We're looking at how we take what we're going to pilot in Alberta to Quebec, to Ontario, to the other provinces in which we operate. And we're talking about a decade's worth of building to do something which should be super similar, and is how you interact with everything else in your life, banking, retail, even talking to your friends, right? It's all omni-channel. But to move this massive, you know, very inertia heavy healthcare system is going to take decades. I wish it was years. You know, COVID supercharged it. You know, Will, you and I joked that 10 years of our career was compressed into 6 weeks when I rolled out virtual care across the entire country. But it's going to take decades, because unfortunately, I'm just looking at the realistic about how do you put a common EMR in, and then how do you get all the providers and get the doctors to come in and do all those things. So next year, I wish, but you know, we're realistic about it and we've got a vision for it.
Wayne, it might get easier if we have less money. Erik?
Maybe.
Yeah, I just want to pick up on the appetite for risk reward models from the government to give, you know, everybody, whether they're a nonprofit or private or community agency, incentive to take on more complex tasks like this. And to incent, I think we're going to have, you know, we're lucky in one province where we control the ambulance system, the home care, telehealth, et cetera, but that doesn't exist in most places. So we're gonna have to find economic models that support consortiums to come together. I mean, they're doing cool things in the NHS with their integrated care systems, where they're, literally putting legislation in place and governance models to make sure that privates have a voice, that nonprofits have a voice, patients have a voice. So how do you bring that together with an economic model that's going to sustain, primary care and care coordination?
Darren, and then Zayna, last word.
So the next year for us in primary care is going to be really challenging in that we're just simply freaking exhausted. And I'm not even talking about burnout. I'm just talking about the fact that we have just been working full tilt for 2 straight years in primary care generally. And as bad as it is for doctors, it's even worse for nurses. My biggest worry right now over the next year is talent flight. How many of my friends are talking about retirement now early? How many nurses have left the profession? How many ICU beds are not open because they have a staffing shortage, which is not going away? To me, that's the big issue right now. And the economics of that, we can't even really measure. You can't just get people out of nowhere. So it's going to be a real challenge for us this next year.
Zayna, last word.
Just 2 points. I'll build on Eric's. I think there's certain pockets in Canada that have awesome people who control all the levers, who want to do dangerous stuff. I look at Nova Scotia, our friends out in BC. I kind of enjoy working with those folks. So I think there are going to be certain things are going to move faster because the people who hold the levers want to make them move. But I actually think the answer is going to be at the skirts of the formal system, at the outskirts is where the action is going to go down, and it's going to move a lot faster, and patients will demand it.
Well, listen, thank you to the 4 of you. You guys have just been amazing, and this is met and exceeded all my expectations. So thank you very much. Thank you to the audience for joining and for joining all year long. And thank you to Rosemary Hannum, who's been my partner in crime on putting these on for I don't know how many years now, 8 or 9. And always a ton of fun working with Rosemary. She does such a great job making the Sandra Rotman Center and all of Rotman Healthcare programs work. So thank you, Rosemary. And thank you all. And bye-bye, everyone. We'll talk later.
Thanks to you, Will.
Thanks, Will.
Thank you.
Thank you.
Thanks, everyone.
Great job, Will.
Oh, you guys did